oriented towards primary health care. And again, I won't stop to tell you how we rank the countries, but it's all available either from me or from the book. But this is a plot of the ranks of the countries on the policy characteristics, the system characteristics on the bottom, and the practice characteristics of primary care along the slide. And you can see that there is an almost perfect relationship, such that the stronger the national policies for primary care, the stronger the primary care practice. So overall, countries that achieve better health levels are primary care oriented, have more equitable resource distributions, have government-provided health insurance or health services, have little or no private health insurance, and have low or no co-payments for health services. Now, is primary care as important within countries as it is between countries? Because what I have shown you so far is evidence from cross-national comparisons. And here is a slide from the United States. We have 50 states in the United States. And the states vary very greatly in terms of the number of primary care physicians per 10,000 population that they have. And in this slide, we plot the primary care physician supply against life expectancy. And you can see, again, that the more primary care physicians to population in the state, the higher is the life expectancy. And it is a very significant relationship. In both England and the United States, each additional primary care physician per 10,000 population, and that's somewhere between a 12 and a 20% increase, depending upon what you start with, each additional primary care physician is associated with a decrease in mortality of between 3 and 10%, depending upon the particular health measure that's used. And this is true even after adjusting for sociodemographic and socioeconomic characteristics. This is a study in the United States from a national health survey, and it's a study of healthcare expenditures and mortality in a 5-year follow-up. The study found that adults ages 25 and older with a primary care physician rather than a specialist as their personal physician. In the United States, you can have a specialist as your regular source of care. But adults with a primary care physician rather than a specialist as their personal physician have 33% lower costs over a period of 5 years and were almost 20% less likely to die in the 5-year period, even after controlling for age, gender, income, insurance, smoking, and perceived health status, and 11 different major health conditions. And here's a study that comes from Petropolis, not so far from your state. And it was an interview survey of people receiving their health care in different primary care health care centers. And each of those health care centers were rated given a score, were rated according to how strong the characteristics of primary care were in those clinics. And this slide gives you the odds ratio for reporting health as good or excellent, depending on various characteristics. And you can see that the top line, that is the primary care score, is the most important determinant of self-reported health in this area in Brazil. It's more important than the age of the person, than whether or not the person has a chronic disease, more important than whether the person has had a recent illness, more important than household wealth, more important than their education, and even more important than the particular clinic type. That is, when the primary care quality was rated in each of these healthcare centers, the most important characteristic was the primary care quality in terms of relationship with self-rated health. Now, many other studies done within countries, both industrial and developing, show that areas with better primary care have better health outcomes, including total mortality rates, heart disease mortality rates, infant mortality rates, and earlier detection of cancers such as colorectal cancer, breast cancer, uterine or cervical cancer, and melanoma. The opposite is the case for higher specialist supply, which is associated with worse outcomes. And most people are very surprised when I say that, because we all think, well, if you have wealth, you buy specialty care and you will do much better, and it isn't true. So let's look at some evidence on primary care versus specialist physician supply. And I will show you some summary of several studies. The higher the ratio of medical specialists, not primary care, specialists to population, the higher the surgery rates, the higher the performance of procedures, and the higher the expenditures. The higher the level of spending in geographic areas, the more people see specialists rather than primary care physicians. And quality of care, however you measure quality of care, and many measures have been used, both for illnesses and for preventive care, are no better in higher spending areas, and in most cases are worse. So we know that inappropriate referral to specialists leads to greater frequency of tests and more false positive results than appropriate referrals to specialists. Inappropriate referrals to specialists lead to poorer outcomes than appropriate referrals. The socially advantaged have higher rates of visits to specialists than the socially disadvantaged. Although greater primary care physician supply is associated with better health in populations, greater specialist supply is not generally associated with better health outcomes. And I thought I had a slide here, but I think not, but so I'll summarize very briefly some study that was published in The Lancet within the last month. And it was a study of neonatal mortality in Pelotas from 1982 to 2004. Even though infant mortality has been decreasing in Brazil, and it's been decreasing in this state, in Pelotas, neonatal mortality has been stable through the 1990s. It hasn't decreased at all. At the same time, there has been no change in neonatal mortality. The birth weight specific mortality declined about 50%. That is, those infants born at low birth weight were doing better and better in terms of survival. However, the frequency of preterm births rose from 6% in 1982 to 16% in 2000. The number of ultrasounds that were done in 2000 was 97% of all pregnancies, for a procedure that really does not have to be done for everyone. That the delivery induction rates rose from 3% in Pelotas to 45% in Pelotas. Induction is mainly done for post-mature infants, for deliveries that have gone past term. But in Pelotas, they're now using it more and more for early induction of labor, and hence the rise in preterm births. And the C-sections rose from 28% to 43% of deliveries, and this is the case both in the socially disadvantaged populations as well as in the socially disadvantaged populations. So here you have a situation where I believe over-specialization of neonatal care has not been advantageous to the population of that city. And perhaps if they turned their attention and their expenditures to better primary care for the mothers, they wouldn't have to do all this saving of low birth weight and preterm infants. Now, let's see, a major function of primary care is to assure that specialty care is more appropriate and therefore more effective. And I think this is a challenge to all of us that are involved in primary care, not only to do a good job at what we're doing, because we're already doing that, but also to make sure that specialty care is more appropriate. Now I want to ask the question about equity. Does primary care reduce inequity in health? Because it's one thing to improve the health statistics of a country or a state or a region or a city, but it's another thing to reduce the disparities between the more advantaged and the less advantaged people. So what do we mean by equity first? Equity in health is the absence of systematic and potentially remediable differences in one or more aspects of health across population groups, defined geographically, demographically, or socially. I like this definition much better than the older definitions that said equity was fairness, because even though I believe in fairness, I don't know how to measure fairness. So this definition gives me a way and gives you a way to determine what you are doing to reduce the differences between health of different population groups, because you can measure these differences. So let me show you some evidence that primary care helps to reduce inequity in health. In the U.S., in state-level analysis, the U.S., by the way, has a very inequitable health system and very inequitable distributions of health. In state-level analyses controlled for demographic and socioeconomic variables, a 20% increase in the supply of primary care physicians, that is one more per 10,000, is associated with a more than a 3% lower age-adjusted mortality among our biggest minority population, the African American population, and a 2% lower age-adjusted mortality among the white population. That is, a larger effect among the more deprived population. The greater primary care resources are even more beneficial to the disadvantaged group in the population than they are to the majority white population. In 7 African countries, the highest 1/5 of the population, the most advantaged 1/5, receives well over twice as much financial benefit from overall government spending than the poor do. That is, 30% go to the richest 20%, and only 12% go to the poorest 20%. But for primary care expenditures, the poor to rich benefit is much lower. That is, 23% go to the richest 20%, and 15% go to the poorest 20%. And let Dr. Davidson Gwatkin, who is an international expert in thinking about equity, to say that from an equity perspective, primary care represents a clear step in the right direction. There aren't very many studies from countries in the South, and especially from the poorer countries, but this is one study that was done in Bolivia in the early 1990s. And in Bolivia, they reformed certain areas towards primary care, and they compared the outcomes with adjacent areas which served as the comparison group, and also with national data on completed vaccinations, on 3 or more growth monitorings, and on age-specific mortality in infancy, at 1 year, at 2 to 4 years, and at 1 to 4 years. And you can see from the charts, because you have the charts in front of you, that the areas that were reformed to strengthen them for primary care achieved much more than either the adjacent areas or the country as a whole. So the evidence is not only from the industrialized countries, but is also from the developing and the moderately developed countries of the world. Now we come back to that first slide, the graph from the Karolinska Institute on child survival to age 5. And what I've done is to pair countries that had high child survival to age 5 with countries of the same wealth but that have low child survival. So Sri Lanka and Malaysia and Costa Rica and Jamaica and Nicaragua and Egypt have some of the highest child survival statistics, and each one is paired with a country that has low child survival. Sri Lanka with Ivory Coast and Malaysia with Brazil. And these are 1995 data. Costa Rica with South Africa, Jamaica with Ecuador, and Nicaragua with India, and Egypt with Ivory Coast. Now the numbers like the 1.1 and the 2.6 and the 2.1 is the ratio of the percentage expenditures, government expenditures for health from the government to the poorest 20% versus the richest 20% of the population. So the countries on the left, except for Egypt, actually spend more on the poorest segments of the population than the countries on the right, which spend a very low amount on the poor populations as compared with the rich populations. And you can see that for each pair of countries, the number of additional children lost per 1,000 in the countries where the government expenditures for primary care are low. In Ivory Coast, 150 more children per 1,000 die than in Sri Lanka at the same wealth, but with very different government expenditures for health. And you can see that the same is the case for the other pairs. The more the government spends on primary care for the poor, the better the survival. So now we come to the conclusion of just this very brief summary of studies that have been done. And Virchow said that medicine is social science and politics is medicine on a grand scale. Along with improved social and environmental conditions as a result of public health and social policies, primary care is an important aspect of policy to achieve effectiveness, efficacy, and equity in health services. That although socioeconomic factors undoubtedly influence health, health services are a highly policy-relevant influence because their effect is clear and relatively rapid, particularly concerning prevention of the progression of illness and effects of injury, especially at younger ages. In order to move ahead with reorienting primary health care and primary care, that is, the policies at the national and regional level and the practices at the local level, it's important to know that we know what primary care is and what it accomplishes for better population health at lower costs. We also know something we didn't know 20 years ago, that it's possible to measure, evaluate, and monitor both primary health care, the policies and programs, and the practice of primary care. Policy is developed at the national and regional levels. Policy makes it possible to develop and implement primary care at the local level. Policy makes it possible to assure better relationships between primary care and specialty care and more effective use of referral services at the regional level. So I think you are embarking on this program. You have embarked on this program, and you are increasing the speed with which you do it. And I look forward to great things from you in this state and from Brazil in general. Thank you.
Convidamos o senhor secretário de Estado da Saúde, Dr. Osmar Terra, para coordenar a mesa, e aos senhores Dr. Djalmo Sanzi Souza e Elson Romeu Farias, do Programa de Saúde da Família, para também comporem a mesa para a seleção de perguntas.
Bom, as perguntas estão sendo recolhidas, mas nós vamos fazer uma exceção aqui no início. As 3 primeiras perguntas, quem quiser fazer ao vivo, pode fazer desde que não seja um discurso muito comprido. Pode fazer também. Está aberto aqui para pelo menos 3 questionamentos aí, falados e os escritos. Enquanto não tem aí os questionamentos falados, nós vamos para o primeiro escrito aqui. João.
Há uma colocação, uma pergunta, melhor dizendo, encaminhada pelo Gilmar Basso. a professora Bárbara Starfield. Falar em atenção primária é fundamentalmente referir-se a novos processos de trabalho na atenção à saúde. O que podemos esperar e fazer em termos de medidas necessárias que alterem profundamente esses processos de trabalho na produção de saúde da população ou das populações?
Yes, well, I said that we know what primary care is. And if we know what it is, we can measure it. And we can do it. Now, primary care is really 4 things. It's accessibility when people need care. It's person-focused care. As Dr. Terra said before, you said that, person-focused care. Not disease-focused care. And it's continuous over time. It's care that is comprehensive. And comprehensive means that it takes care of all the health problems in the population, except those that are too uncommon for the primary care professional to deal with them. Yes, you need specialists for the rare conditions. But primary care takes care of all the problems that are not uncommon. And that's why you need to know what are the distribution of problems in your population. Because you need to know what's common and what's not common. And the 4th characteristic of primary care is that it is integrated, so that when people have to go elsewhere, either to specialists or to other sectors, the primary care service integrates or coordinates the care. And yes, and there are 3 other characteristics which follow from the 4 main ones. And that's family orientation and community orientation and cultural competence. So we know what to strive for, we know what to work for. And we can show the importance of each of those characteristics that together make up primary care. I hope I answered the question.
Estamos fazendo a seleção aqui. Temos uma pergunta bem objetiva. A senhora acredita no trabalho multiprofissional e na interdisciplinaridade?
Yes, of course. Because there are many things that physicians are not very good at, and there are some things that nurses are better at, and dentists are better at. But I must say one thing, is that I am not in favor of organizing teams very rigidly, because the composition of the team will differ according to the needs of the particular population.
Muito bem. Eu vou tentar juntar 3 questões. Há algum estudo que comprove o bom impacto da multiprofissionalidade na atenção primária? A pergunta é feita por meus colegas da Unidade Básica de Saúde 6, da Vila São Miguel do Murialdo. Junto com essa questão, qual a importância dos profissionais não médicos na atenção primária? E com a busca de um impacto social na melhoria da saúde da população, por que não tem um assistente social numa equipe de saúde da família, considerando o conceito amplo de saúde?
Yes, we have been looking for evidence on the composition of the team for many years.